Hello and welcome to this Radcliffe Cardiology event entitled How to Perform PCI in Coronary Bifurcation Lesions in 2021. Today's webinar is supported by Philips. I'm Dr. Chris Cook, an interventional cardiologist from the Essex Cardiothoracic Centre in the UK, and I'm delighted to be joined live by Professor Robert Gill from the Clinical Hospital of the Ministry of the Interior and Administration in Warsaw, Poland.
Thank you very much for the presentation. It's a pleasure to be here.
Professor Gill will be providing us a contemporary overview on the percutaneous treatment of bifurcation lesions. Now, before we start, let's take a quick look at the learning objectives for today's event. Our first learning objective is to define a common language for the assessment and treatment of coronary bifurcations. Secondly, we aim to inform about the prevalence and classification of bifurcation disease and illustrate the utility and functional and imaging-based assessment. And lastly, we will establish a state-of-the-art treatment algorithm and drill it down to the use of the most appropriate techniques and technologies. Now, before we begin, just a quick note to our audience. This is an interactive session, so you'll have the opportunity to ask Professor Gill questions. To do so, please type your questions in the form on this broadcast page, and Professor Gill will answer as many of them as possible in the latter part of the webinar. Okay, so I'm going to stop talking now and hand over live to Professor Gill for our session.
Good afternoon to everybody. I hope I will be able to present you my philosophy regarding coronary bifurcation treatment. And just to start immediately, we all know as interventional cardiologists that performing procedures is most exciting and the best part of our work. But we have to remember that always during the interventional procedures we can face difficult decisions. So therefore, the background, the scientific background, the knowledge regarding the region of interest, I mean coronary bifurcations, is very important. Therefore, I would like to start showing you about the standard language and some rules which are necessary to take a right decision during coronary bifurcation treatment. First of all, we have to remember about fractal nature of the bifurcations. So it means that knowing, let's say, at least three parts of bifurcation, we can calculate the potential size of the vessel, which is necessary to choose the right devices for percutaneous coronary intervention. The second point, which should be taken into account, is regarding a structure of bifurcations. Okay, this is fractal, but we have three parts, which is proximal main vessel, distal main vessel, and side branch. Please remember about the angles, which are also very important, because taking into account this knowledge, we can communicate each other very easily, because this is a kind of standardization of the knowledge. There were a lot of classifications trying to describe coronary bifurcations. But this is a merit of Dr. Medina from Spain. His classification, which is relatively simple, quite understandable for everybody. As you see here, we should use 3 digits. One means stenosis, 0 lack of stenosis, and the sequence of numbers say us where there is location of the lesion. Using the same classification, we can also assess trifurcation, not only bifurcation. So it really helps us to understand, even by the home, which we are talking about. The next point, which is very important and should be considered by every interventionalist, is a knowledge about atherosclerosis progression in coronary bifurcations. So we have to take into account that based mainly on coronary angiography, we can miss the real size, the real plaque distribution within the coronary vessels. So therefore, you have to remember about the rules, about the hemodynamics of blood in bifurcations, just to be prepared where the plaque formation starts and where you can meet some problems when you base your decisions only on angiography. Of course, we have to remember that left main is a special animal. We know a lot of peculiarities regarding this most important part of coronary vasculature. We have to remember that atherosclerosis usually presents with longitudinal diffusion. There is a relatively large angle between distal main vessel and side branch. We have also we have to remember that in majority of cases, circumflex artery, which is mainly side branch, is very important in terms of magnitude of myocardium distribution, blood distribution. In terms of plaque distribution in the left main, which is very, very important in terms of decision making regarding potential percutaneous treatment, we know from angiographic studies how does it look like, and of course it's very difficult to remember in which percentage you can adjust to the particular patient. However, mostly the plaque distribution exists let's say in left main, but they are spreading into LAD and circumflex. So this is very important information which is necessary to take a proper the optimal technique for left main, distal left main treatment. But of course, we can facilitate our decisions. We can simplify our daily work, since we are able to use intravascular visualization. Here you can slide showing how it should be done with two pullbacks from LAD and from circumflex artery. We can use longitudinal projection, looking at the plaque distribution. What about the angles, and we can use this information to choose the right strategy for treatment. Of course, we have to remember also about optical coherence tomography, which is also very useful for percutaneous treatment in coronary bifurcations. However, in terms of left main, we have to remember that proximal part is not very well visualized. We can miss some important moments. So therefore, especially when the entire left main is involved in stenosis, so we have to distinguish whether IVUS is more appropriate in such a situation. However, with the OCT, we can get a real great pictures like electronic from electronic microscope. Here you can appreciate the differences in luminance and stent measurements between these two techniques. we have to remember that that with OCT there is a relatively smaller diameters and areas compared to ultrasonic. It's at least 15% differences. However, still we can base our decision on these two techniques. This is not a problem. In terms of distal left main, we have to remember that much more data was gathered in terms of IVUS usage for distal left main treatment. And here you can appreciate a proposal how we should take into consideration the minimal lumen area based on IVUS in terms of final decision. So this 6 square millimeters is not 100% sure a cutoff criteria to treat or not to treat. We have to remember about so-called a gray zone between 4.5 and 6 square millimeters. In these situations, especially when we don't have symptoms, we don't have confirmation for ischemia, we need to check this lesion with functional techniques as FFR or IFRs. The first summary of already presented slides, I would comment with this proposal of algorithm, which is very important in nowadays because first of all we started to at least 10 years ago we started to treat more and more older people. Of course, there are much more calcifications in such older patients than in the younger ones. So therefore, we know that we should test, we should search for calcifications in coronary bifurcation as well. And here you can appreciate the proposal how we should tackle the information given by angiography, but also with IVUS and OCT in terms of choosing the right devices for plaque preparation. Nowadays, this is not only a couple of kinds of balloon, NC balloons, double layer balloons, cutting balloons, but we should take into consideration atherectomy. This is rotational and orbital. There is also a laser, there is also a lithotrip, intravascular lithotrips, and then there is no time to discuss in details. However, this is worth to prepare, to perform pre-procedural visualization, just to take right decisions, the right dimensions in terms of devices, just to optimize let's say the final results. But of course, visualization, this is one piece of the true in terms of coronary bifurcation treatment. We have to remember about functional assessment, which is also very important. In nowadays, we can use not only FFR measurements, but also no hyperemic parameters, and IFR is most tested in thousands of patients with randomized trials, so we can rely on these results. We can also use this functional assessment as a follow-up in a follow-up phase, just to be sure whether we should say make re-PCI to improve flow in coronary bifurcations as well. Here you can appreciate relatively recent paper showing us that cutoff criteria for IFR, which is 0.89, is also useful for left main assessment. This is very important because this is very rare, less than 5% where solely left main is involved in atherosclerosis. Usually we have much more lesions in LAD and circumflex arteries. So therefore, FFR assessment for such very complex atherosclerosis is not so easy, and we have so many doubts whether left main is involved or not, which is whether it's significantly stenosis or not. So with IFR, usually, especially with scout pullback procedure, we can really measure this quite easily. This is my second, let's say, proposal as a kind of a summary. What was already was told, that with angiographic and then additional invasive diagnostic methods, visualization and functional assessment, we can really discriminate the group of patients with bifurcations for this one which should be treated or not should be treated. Please take note that this is very important to discriminate left main and non-left main lesions as well. And here you don't see the proper or proposed techniques which can be performed in such a situation. So therefore, let's start to discuss the next very important issue: how we should manage coronary bifurcation with one stent or two stents, because we should forget simple ballooning as a primary technique for coronary bifurcation treatment. I don't want to go into the details with drug-eluting balloons which can be used for bifurcation, especially in small vessels. However, in general, drug-eluting stent is the best device, the best weapon against coronary bifurcation. So there's still ongoing debate, one or two stents for bifurcation as a European bifurcation consensus. This is a provisional T-stenting as a preferred technique. And using this technique, we should keep this kind of principle, KISS, as a simple and swift and safe as a performing coronary bifurcations. And this is also a merit of European Bifurcation Club, which was established in 2004 by our French colleagues, that European Society of Cardiology took these recommendations for their guidelines. And here it's written that stenting of main vessel is followed by provisional balloon angioplasty with or without stenting of the side branch is recommended for PCI or bifurcation lesion. There's also a second very important issue, that in terms of true bifurcation lesions of the left main, the double kissing crash technique may be preferred over provisional T-stenting. We will come back to this issue a little bit later. And then here you can appreciate relatively fresh proposal of MATS2 classification prepared by people of European Bifurcation Club, showing which techniques should be used and special and following steps for all of the techniques you can appreciate here. What is very important that on contrary to the previous proposal, this is a much more detailed, based on scientific background, showing also additional maneuvers, additional steps which should be implemented to the moment of simple stent implantation. Another important issue which is associated with this MATS2 classification is the fact that inverted techniques, inverted provisional T-stenting, inverted culotte or decay crash, they are also proposed in a special anatomical situation. Here you can appreciate the issues which are very important and regarding one stent or two stents techniques. There is no time to discuss very in details. However, we have to remember that with one stent we can easily lose side branch, so we have to be prepared for that. The one stent approach doesn't mean that this is the only stage which step which should be used, and we have also remember about some biases which are associated with two stents techniques as a problem of additional metal layers facilitating thrombosis or restenosis, for example. When we start to think about which techniques should be used for proper treatment of coronary bifurcation, we have to think about side branch. I mean, the identification of clinically relevant side branch is the most important moment in terms of choosing the right techniques for coronary bifurcation treatment. And of course, you have a lot of techniques which you can use to get the final decision. However, today I would like to focus on this geographic assessment, which is very easy, can be very easily used by interventionalists. Here you can see the proposal of Bonku, who proposed a very clever, I would say, score. This is no score, where the three parameters should be used. This is size of the vessel diameter. I mean side branch, of course. The number of side branches, and the highest. So it means yes or no additional side branch below the one which is assessed. Here below you have a much more let's say complex proposal for modified SNOOC, but I must honestly say that this the first one is very convenient and very easy to be used. But of course, in terms of certification for coronary bifurcation, as for other part of coronary vasculature, is much more complicated, because on one hand we have to take into consideration the angiography and clinical status of the patients, but then we have based our decision one or two stents on a much more detailed features, and if you look here, this resolve score helps us to assess whether one stent is enough or not. But definition criteria, which becomes more and more popular right now, tell us whether lesion is complex or not. Complex means the second stent is demanded. Here you can appreciate some details regarding this definition from this trial definition, but some details regarding how we should calculate this score. I really suggest to use it, because it makes it makes your life much easier when you base your decision not only on your feeling, but also on a very strict numbers and analytical features. Some words regarding how does provisional T-stenting should be performed. Here you can appreciate that stents should be sized based on distal reference. Then the second, but of course two wires should be inserted into into bifurcation, side branch and distal main, then sizing of the stent implantation, then the second next step, very important, this is a proximal optimization technique, then rewiring of the side branch, and then here you can appreciate kissing balloon, which is a so-called old approach. And the procedure in that proposal should be finalized with a second pot, so a repot. But we know from the literature that we can improve our results with another approach, using, for example, after pot side branch dilatation, and then finally, let's say next pot, or we can perform, let's say, without pot. But if you look at the results of this experiment, you can appreciate that the best results were achieved in this approach, pot side dilatation pot, that nowadays it's thought as an alternative for final kissing balloon. In terms of proximal optimization technique, this is very important to use and see balloons, but positioning of this balloon is very crucial, because only in this mid position we can achieve what we really need to achieve a good access to side branch and full apposition of the stent struts for proximal part of the bifurcation, without changing the position of carina when we oversize with this during the pot, the beginning of distal part of the stent. And then this slide illustrates how does it look like. Here you can appreciate longitudinal projection. You show here distal main vessel. This is proximal main vessel. This is side branch. Here you can see carina, and then when you use let's say stent with a bigger diameter than distal reference, then or if you use perform per pot too deeply, you can really change the position of carina, and then you impair the flow for side branch. So this is a very bad situation. We are forced to recreate the flow for side branch. And of course, we have also remembered that after main vessel stenting, we have not only carina shift, but also some plaque, longitudinal plaque shift, some spasm, might be dissection, and then there is a problem whether we should treat side branch or not. Here you can appreciate the information which you can get by functional side branch assessment using pressure wire. In this particular case, there was no need for intervention for side branch. We have remembered that characteristics of the stenosis, also the length is very important, and sometimes even relatively narrow stenosis is not significant because it's very, very short. This is a result of the investigations of Bon Ku who showed us that in terms of side branch compromise by main vessel stenting, only less than 40% of lesions needed to be retreated with balloons or neck stents. So we have taken into consideration that the visual assessment and belief in angiography is not the best idea to be, let's say, optimal in terms of coronary bifurcation treatment. In this slide, you can appreciate the truth that provisional destenting doesn't mean forbid next steps to improve the results of main vessel stenting. Here you can appreciate that in terms when you are not happy with the result, you should take an action. You can redilate a side branch. You can make a kissing balloon. You can also use a report afterwards, just to have the opportunity to assess whether it's fine or you need a second stent. If yes, this is a bailout side branch stenting, and then you need to take a right choice. And then we have remember where is your wire in side branch. Whether this wire reached distal or proximal strut. So when this is a distal strut, so the provisional destenting, this is a simple T stenting procedure could be performed. When this is a proximal, we have at least two options. This is tap and or culotte. Today we can say about decay culotte, but this is another story. How we can improve this moment, just to use intracoronary visualization. Here you can appreciate the results of many trials showing that the results also for long term are much better in the patients where this intracoronary visualization was used. How we can optimize using these techniques, mainly IVUS. Here you can appreciate here. This is not only the minimal lumen area or minimal stent area. We have also looked at the apposition of the stent. We have looked at the edge dissections. We can look at the references proximally and distally, just to let's say to achieve best expansion of the stent, just to have opportunity to recreate laminar flow within the stent. And of course, with OCT, it's also possible. It's that the results in terms of illustration are much better for part of interventionalists. But we have to remember that in terms of distal left main, this is not always the case. In terms of optimization for left main percutaneous treatment, we have to remember that still so-called Kangs rules are valid. So this rule 5, 6, 7, 8 square millimeters for let's say for left main assessment after stenting, it's valid. However, we have to remember that Caucasian race means bigger people, bigger heart, bigger diameters of the coronary arteries. So therefore, based on data from Excel trial, we can easily add we'll say up to 1 square millimeters to achieve a real optimal results after distal left main stenting. Just to show you that regarding two options of distal left main stenting, provisional and two stents technique, we have to remember that our assessment shouldn't be focused only for minimal stent area, but also for these additional features, which I have already mentioned. And based on last papers, we can base our decisions in terms of optimal magnitude of this minimal stent area. So the most important is just to have between 80 and 90% of proximal or average proximal and distal cross-section area. So this is very important to assess a real reference segments for coronary arteries. This is very important. Very close, very similar assessment for two stents techniques, and of course someone can say that based on guidelines of European Society of Cardiology, for true bifurcations, we should, especially for distal left main, we should take mostly double kissing crash techniques. However, we are close to say that the trial DK crash 5 was not quite fair for provisional T stenting. So therefore, we shouldn't forget the other techniques. And here you can appreciate my proposal for optimal PCI strategy for coronary bifurcation lesions, taking into account also the angulation between main vessel and side branch, and also assessment of complexes and simple lesions. Personally, I believe that meticulous analysis of this diagram can give you some options to increase or to facilitate your decisions for coronary bifurcation lesions. Thank you very much for your attention.
Great. Well, thank you very much from me, and also on behalf of our audience. I'd like to say thank you, Professor Gill, for a really excellent and informative lecture on coronary bifurcation PCI. It's now time for today's Q&A session, and we've had a fantastic response from our viewers. And I would like to remind our audience that they can still submit their questions to Professor Gill. So, Prof, as a first question, perhaps, let's take the example that you've performed a provisional approach, which has involved LAD to left main stem PCI. And the circumflex ostium looks good and the patient remains stable. Would you routinely cross back in and perform a final kissing inflation of the circumflex, or would you leave it alone?
This is an excellent question. Thank you very much. I must honestly say that 5 years ago, I routinely wired side branch, so circumflex artery, and with relatively small balloon dilated in terms of performing potential access to circumflex artery for next time in terms of in the need of or potential need of PCI. But you know, with new drug-eluting stent generations, especially designed for side branch with relatively big cells, after proximal optimization technique, I don't think it's necessary to do that, because first of all, we should use much bigger balloon than we did it in the past. Then we can really hard orifice of circumflex artery. We don't really change hemodynamic for circumflex artery. We can destroy a position of the stent in main vessel, also in proximal in distal part. So this distortion is not well accepted by the vessel. There is a need a redilation for report. So just to summarize, this is not routinely done. Sometimes if I have any troubles, I try to go with IVUS or CT to assess how the access to side branch in this moment for distal left main for circumflex look like.
Fantastic. Thank you. That's really clear, and also something that our audience can take into their clinical practice straight away. We've had actually quite a few questions on the chat, which relate to what are your criteria to intervene on the side branch in terms of whether that be a kissing inflation or indeed moving on to bailout stenting?
I would say that in terms of non-left main, if I see TIMI free flow, if there is even if is indentation more than 70% diameter stenosis, but this is just indentation due to the struts of the stent. When I have bigger than 2.0 side branch, longer than 72 millimeters in CT, it's possible to do that. Then I try to redilate such an indentation. This is so-called side ballooning. This is not kissing. And we know from the literature as well that if you don't exceed the size of the balloon for side branch over 2.5, you need to perform kissing. If not, less than 2.5, there is no distortion. So therefore, I decreased almost to zero kissing balloons for side branch treatment for non-left main bifurcations. For left main, this is another story because, as I mentioned during the presentation, circumflex arteries is very important, and it distributes blood to more than, in majority of cases, to more than 10% of myocardium. So therefore, we have to take care of this vessel. And I believe that inspection with IVUS or CT helps a lot to decide whether we should fight, whether we should use a second stent. So I almost always use the final, let's say, base my final decision on intravascular imaging.
Thank you. Well, you've answered another one of the common questions that has arrived, which is, do you consider intracoronary imaging mandatory when performing left main stem bifurcation PCI?
I'm a lucky guy because in my country, since 3 years, we have a full reimbursement for left main stenting in terms of IVUS usage. So therefore, it's hard to let's say, even think not to use IVUS for eligible left main treatment. I'm talking about eligible left main treatment. In these cases, it's not justified not to use, because this is the only moment where we are allowed, let's say, to take the work from cardiac surgeons. Their results are not bad. Our results without IVUS are not so good. But in terms of in urgent situations where there is no left ventricle assist device to be used during the night duty, where you are only one in cath lab, there is no easy to set up everything. You know, I can imagine this. I'm still active interventionist, so it can happen. But then you can do at least so-called IVUS for poor people. I mean, you can use in your geographic machine this option for enhancement of stent enhancement, showing you how let's say the struts are posed, what is the shape of of the stent. So it's worth to be be done. And then at the end, if you stabilize the patients when you have still strength, it's not so bad to perform a final run to assess whether you achieved optimal results or not. But on the other hand, with this final run, you can make some hard for the proximal struts of the stents, especially when you forget to perform properly proximal optimization technique, and then you can create longitudinal distortion of the stent. So therefore, in eligible, we should perform always. In urgent cases, as often as possible.
Fantastic. That's really clear, and I completely agree. And you've also talked about the critical role of POT any time that you're considering rewiring or introducing new kit into that.
Very good remark, because maybe I missed this moment, but at the beginning, we used to think whether this POT is necessary or not. But right now, we know that without any additional assessment with OCT, IVUS, it gives a benefit to the patients. The rule is at least the short NC balloon used for POT should be in terms of size at least as big as proximal reference diameter is, at least. Usually, when you don't have IVUS, you can add to your angiographic diameter at least 0.5 millimeter.
Thank you. That's a very useful tip. Do you always mandate the use of non-compliant balloons for POT? Do you ever use semi-compliance?
Well, in my opinion, why I use NC, it's not very often told, but for me it's simple. The diameter of NC balloon is much more predictable than a semi-compliant. So it means if you need 3, you have close to 3 with NC balloon. With semi-compliant, that, you know, if you really have very elastic, even not very hard, but elastic artery, you can go, or plaque, you can got quite good result, but after deflation, it's not the same. So the predictability of the results with NC is much higher. But of course, sometimes, especially during night duty, when this is a second set or fourth patients, when we are short of length of the balloons. So if you have just semi-compliant only, but 5-0, which you need to redilate your left main, so it's much better to take this balloon, whether instead of 4-0 up to 30 bars to make rupture and problems with left main in a patient.
Thank you. So we've got a changing the train of thought slightly now. We've got another question that's come in, which says, do you modify your antiplatelet duration or regime for patients who have undergone bifurcation PCI versus the more simple single vessel PCI?
Now, this is a great question, especially when we are facing a lot of informations. How is good to shorten the DAPT after coronary stenting, especially for patients with a high bleeding profile. I must say that there are a couple of situations where I have some doubts how and what should we do. First of all, in terms of eligible cases, I believe that in majority of cases, this dual antiplatelet therapy based on aspirin and clopidogrel is fine. But on the other hand, when we have distal left main with 2 stents, with additional stents implanted in other coronary vessels, this is a moment when I start to think, okay, maybe we need a stronger antiplatelet drug, not clopidogrel, but ticagrelor or prasugrel. And then I look at this profile for bleeding. This is high bleed risk patients or not. If not, in such a situation, I would say I would go for that, and might be after 3 months I would leave only ticagrelor or prasugrel.
Thank you. That's very helpful. And for the last 2 questions now, we're going to really use your expertise and knowledge of the field. And so the first of these questions is, what do you think are the biggest unmet needs in bifurcation PCI in 2021?
I must say that results achieved for non-left main bifurcations are very good. And of course, might be we'll change something, I don't know what. Might be we'll find easier and a better scoring system when we should use a second stent for non-left main bifurcation. So I don't think we can achieve really more. Might be with new generation of bioabsorbable scaffolds. Might be this is something which can be achieved, and of course I truly believe that we should more often use intravascular visualization for this non-left main bifurcation. In terms of left main, this is another story, because the results are not always as good as we would like to have. And of course, we can improve our results with already not bad devices using intravascular imaging. But we need to know much more about our choices based on plaque characteristics. And I'm very close to the idea. My team is working on that the magnitude of calcification, the calcific load of the distal left main is a crucial moment whether we should or not to perform percutaneous treatment. Because especially the localization of calcific nodule spreading from distal left main towards proximal part of circumflex artery, not just a simple calcification, but nodule. It changes a lot, because you can got very good flow for LAD, but you can close with bad anatomy, almost impossible to let's say to achieve optimal results for circumflex artery. So might be in such cases we should use another, not to treat, or we should use intravascular lithotripsy, for example, to make impossible possible. It means to change properly the plaque characteristics to achieve optimal results. Otherwise, we'll never be better than cardiac surgeons.
And the last question, again, drawing on your expertise and knowledge, is can you share with us what you think your personal predictions for the results of EBC main trial will be, which we're all looking forward to being presented at EuroPCR later this spring?
You know, if I remember well, it will be 5 years when this, 5 years ago, they started with this trial. So enrollment was not easy. So I would like to know much more why this enrollment was so long. And then if they show us great results, I will be shocking a little bit, but might be this is the way to choose the right patients for percutaneous treatment in terms of distal left main. But I'm joking a little bit, but because I don't know the results. But and my personal experience is that since I started to do more and more distal left main without choosing which is good for percutaneous, which not. When I obtained very not just big respect from cardiac surgeons, believing in our results, I discovered that the 1 or 2 years results are not so good as I expected. So therefore, I would love to know how they enroll these patients based on that, because it's also very difficult to understand how can we randomize, because this is randomized trial. There is it should be a comparison between provisional T-stenting and two stents techniques. And then this is a very similar situation to the DK Crash 5. That might be that the case which should be treated with two stents because of complex, let's say, distal left main bifurcation. But, you know, the choice was provisional T-stenting. The only explanation from ethical point of view is a fact that for provisional T-stenting, there is always option for second stent. But I truly believe that at least 50% of distal left main can be safely for patients and effectively treated with provisional T-stenting. So I believe that at least 50% of patients will complete the trial without necessity of second stent implantation.
Yeah, you make some excellent points there that I agree with. And I think the whole community is really looking forward to seeing those results. But
this is very important trial. I must say that it's a pity that we have to wait. We had to wait 5 years, but I guess that we'll got very important message how we should tackle today the distal left main.
Great. Well, thank you so much, Professor Gill, for answering our viewers' questions. And it's been a real pleasure having you with us today. So thank you very much for joining us.
Thank you for giving me opportunity, let's say, to be with you, to share my knowledge, some philosophic approach. I hope it will help to other interventionalists, because we have to share our knowledge. We have to exchange our informations, because we still are in charge to treat our patients optimally.
So that was Professor Gill speaking to us live from Warsaw in Poland, and you can find out more about our speaker in the link under the video. I'd like to remind you that today's webinar was supported by Philips and brought to you by Radcliffe Cardiology. And the full recording of this webinar will be available on demand alongside thousands of other educational resources at www.eubcr.org. radcliffecardiology.com. So it remains for me to say thank you to our audience for joining us today. And until next time, goodbye.
Thank you very much. Goodbye.